make sure I remember to do this part. Okay, so this week we're back for Neuronites part 1 of the sensory motor series, but this is night 2 of that. So we're still focusing on auditory issues, in the context of brain injury. And so this is continuing on from what we talked about last week, where we had Dr. Christina Roop come in and teach us a little bit about sort of the, the basics of the ear and how it works, and then sort of variety of issues that we can have relative to a brain injury, and sort of the role of audiologists and sort of what audiology can start to do for us. So I think this was really cool. I could tell you personally, I went back and we started talking to Christina a little bit more about some of the research that she's doing and ways where we can start to, fund those kinds of things, pair them up with, really cool other researchers on campus who can maybe move the needle for electronics or for interventions or for screening tools. So I'm really excited about this area. I really think we've already gotten something really good out of it. And then in steps Gail Whitelaw, who is just a fantastic resource for us. And so I'm really excited about this. Just quickly about next week. Next week, normally we would have like a social night where it's a little bit more about reflection and sharing experiences. And we are going to do social night style stuff in future months. But because we had so many people say yes to present this month, we're going to fit them all in 3 weeks. So next week, we're going to have, a presentation more on music and sort of music therapy approaches for overall healing from traumatic brain injury, but also in the context of hearing. So definitely come back for that. Just a lot of stuff this month, and it's really going to be good. So with that, I think I'll just turn it over to Dr. Whitelaw to introduce herself and take us away.
Thank you. I'm really happy to be here with you, and a lot of this is going to be overlap from what Christina talked about last week because she and I work very carefully and closely together. I'm Gail Whitelaw, and I've been an audiologist for 38 years, and probably 30 of those years I've worked with people who've had traumatic brain injuries and have a significant interest in that. I actually happen to be in a hotel in Chicago right now, and we'll get off right at the end of our talk because I've got somewhere I have to be tonight with this meeting I'm at. But I'm giving a talk tomorrow on traumatic brain injury to about 200 audiologists, because for many audiologists, they don't know much about the population. And for many patients, they talk about this a ton. You may talk about it a ton. You may have raised your hand for many years to say, but I can't hear a noise anymore, or I have this ringing in my ears. And Christina and I work together, and she's much more on the research side and I'm much more on the clinical side. So I'm hoping to give you some clinical ideas tonight, and any questions you have or anything you want to chat about, happy to participate in that. Or my email is on here. You are more than welcome to contact me afterwards and see what you want to see. So hearing and balance issues are really common after traumatic brain injury. I think Christina probably established that for you last week. I probably do more clinical stuff. She's way better at slides than I am. You'll see her slides are way more interesting than mine. We know that hearing loss is pretty easy to identify after a traumatic brain injury. And that's just gosh, I can't hear a sound anymore. Sound sounds muffled to me. And there's a reason for that. There's something that often happens when you have a head injury. The temporal bone is the thickest, most protective bone in the body, because the inner ear, and I know you learned this last week, houses both the balance system and the auditory system. And if your balance system gets messed up in an inner ear issue, it's a very miserable thing. Think about not being able to right yourself. So the temporal bone is really, really hard and solid. And if you get a fracture in that temporal bone, one of the most common ways for that to happen is in a motor vehicle accident, or as people in the TBI world like to talk about it as the MVA. If you have a motor vehicle accident and you get a temporal bone fracture, it's not unusual to have a hearing loss afterwards. I know from working with hundreds, thousands of patients who've had traumatic brain injuries that when you get into the emergency room, oftentimes they don't even look in the ears, But if somebody's bleeding from their ear canal, or if you look behind their eardrum when you use that ear light, the otoscope, you might see some blood in there. That might show that there's a temporal bone fracture. Sometimes it heals on its own and there's no long-term implication. Sometimes it does not heal on its own and there is a long-term implication. And with that long-term implication, it could be you have a permanent hearing loss, or it could be it heals on its own, but it takes a while for that to happen. So hearing loss is the easiest, what we might talk about in thinking about this as the low-hanging fruit, the easiest thing to find. But we only find it if somebody directs you to have a hearing evaluation afterwards. And I'm a great believer that anybody who's had a traumatic brain injury should have a hearing test at some point. And there's lots of reasons for that. The second aspect of something that we see frequently in people who've had TBIs is tinnitus or ringing in the ears. And there's lots of reasons for that. That temporal bone fracture can result in ringing in the ears. I want to tell you that that sound, that ringing, isn't a symptom of a disease. It's a symptom of many things. And it's a phantom perception. So even though it may sound very, very loud to you, and that doesn't dismiss it from being there, it's your brain looking for something. For some reason, your brain, maybe you got a hearing loss as part of your traumatic brain injury, and your brain's like, look, I'm used to hearing that sound and I don't hear it anymore. I'm going to create my own sound. Sometimes when somebody has a brainstem injury or a temporal lobe injury, it results in this tinnitus or ringing in the ears. It can be maddening. It can be very, very loud. I have people with traumatic brain injuries, when they come in, rank order what's most important to them. And they often tell me that that ringing in their ears is the most bothersome thing of any auditory symptom. One of the other things that's bothersome as I'm talking to you about this is that if you get the wrong kind of professional to talk to about it, they may say to you, oh, there's nothing that can be done about that. And that's absolutely not true. So I will tell you, there's lots of things that can be done for tinnitus or ringing in the ears. You just have to be with somebody who knows how to address those things. And then there are these sound sensitivities that happen frequently after traumatic brain injury. It wasn't there before the head injury happened. And now sounds that don't bother anybody else bother you. They sound too loud to you. They sound uncomfortable to you. I have a patient that I work with who's just a wonderful, wonderful man. And when he was hit by a car, he was a pedestrian. And when he was recovering, he realized that everything sounded too loud to him. And he can hear, he lives across the street from a giant eagle. And he says that when the trucks pull around back, he hears very, very loudly the truck sounds. He says he can't hear voices very well when he wants to listen to somebody in a noisy environment. And there's reasons for that too, related to the traumatic brain injury damage. One of the things that is maddening to me, and I don't remember if I put this in the slides or not, so I'll say it now and then I'll say it later, is that many patients that I work with have had auditory symptoms for years. They report them for years. I would rather see somebody right after they have their TBI and are out of the hospital, if you've been hospitalized, and know what you're working with and what I'm working with. But one of the things that's maddening to me is somebody will say, well, I didn't see that you had a concussion. The auditory system doesn't look at gross pathology like that. It can. You could find a lesion or an area of damage after you've had a TBI, but more of it's on the micro level, not the macro level. So it's not something that's so simple that you go in and you take a look at somebody's CAT scan or their MRI and you find something. Oftentimes we don't find it until we do something like a functional MRI, or we do a test that actually taxes the auditory system and makes it work. And that's one of the things. I know that you all want to be good advocates, and I'm going to give you some advocacy rules for working with audiologists. There's something called an auditory processing disorder. And this is very subtle, but very significant for so many of the people that we see that have had a traumatic brain injury. I'm going to tell you anybody that I talk about tonight, I have permission from them to talk about in talks, because they want you to know why maybe things have been missed. And one of the things is that if you have an auditory processing disorder, you often have a normal hearing evaluation. You have a normal hearing test. So the audiologist may say to you, you have a normal audiogram. That's that little beep that you hear and you raise your hand or you push a button when you hear it. You can have that and still have disorders of the auditory system. They're much more subtle. And this is where they start to demonstrate. You could listen to tones all day long and you would hear them and it wouldn't be a problem. And many of you might say to me, I hear those beeps. I have no problem with that. But I don't listen to beeps all day long. So what happens in an auditory processing disorder is it taxes the areas of the brain that are important for certain kinds of experiences. Taxing means it makes them work really hard. And that's what our auditory systems are designed to do. We're not designed to listen in quiet. So what people will often say after they've had a TBI is that in challenging listening situations, they really struggle to hear. They can't hear fast speech and follow it. Speech sounds different than it did before they had their TBI. If there's any background noise, they really, really struggle. And they know that they've been told they have normal hearing, but when their situation is taxed, like in the real world, like that person goes back to work, or it's a child. I work with a lot of children with traumatic brain injuries and a ton of teenagers. And oftentimes when teens go back to school, they might have been a really great student. And now they're really struggling, especially in noisy environments or learning a foreign language that they're not familiar with, or when somebody is speaking quickly, they really, really struggle in those environments. And this is one of my favorite little things for you to take a look at. It's called Erber's hierarchy. And how this thing works is down here on the bottom of the pyramid is detection. This is the most fundamental aspect of hearing, but it's the least critical for you to be an effective listener. It means you hear those beeps or tones. If you don't hear those beeps or tones easily or normally, we can put a hearing aid on you, and that will help you with hearing that. But the next level is, can you discriminate between sounds? So if somebody is saying an S or an SH or a CH, how do you know they're making that sound? And if you have normal hearing by detection, discrimination is supposed to be easy for you. But many people that have had a traumatic brain injury will talk about they confuse sounds when they hear them. And this ties into what Katie's going to talk about next week with speech. But I want you to think about the fact that hearing is more foundational or fundamental to learning to be a good speech language user than you might think. If you can't hear the difference between sounds, it's going to be really hard to follow a conversation. No matter how loud someone makes them, it doesn't do anything for the clarity. And then how do you identify these sounds that we put together in terms of speech and language? And then how do you comprehend all of this? So if you feel like you're not hearing well after a traumatic brain injury, and you go to an audiologist who only looks at detection, only looks at those tones, and when you hear a tone, you push a button, they kind of miss the bigger picture for you. And you haven't really been tested until somebody looks at this whole hierarchy, not just the tip of it. So another reason that we're interested in this stuff after a traumatic brain injury is we want to focus on functional hearing, which is, how do you use your hearing in the real world? Again, I jokingly say none of you listen to tones all day long. If you did, and all you had to do was push a button when you heard a tone and your hearing was normal for hearing tones, you wouldn't be talking about, I don't hear well in noisy situations, or it's very fatiguing to me. And I know that most of you have a pretty good background in executive functioning, either as something that you know as a clinician or something that you know as a person who's had a traumatic brain injury, that when you've got to bring together all that information, it's very hard. And I want you to think about Most of the information that you take in during a day is auditory in nature. There have been studies that have been done that say we spend up to 80% of our day listening as our primary form of getting information. So if you're expected to do that and it's fatiguing to you, you have less resources available for other cognitive tasks like reading or walking or processing language. And there's been study after study after study that I couldn't go into tonight, but there are thousands of studies that show that. So the impact of your functional hearing is really, really critical. One of the main impacts of hearing loss in functional terms is the loss of the individual's ability to communicate with others. So that's not just an executive functioning or a cognitive thing. I want you to think about how important, and I'm preaching to your choir because you already know all of these things, but you go to a doctor's appointment and you're fatigued and they talk fast and maybe they have an accent that you're not familiar with. And maybe they're rattling off jargon and your auditory system only processes half as fast as it did before your accident. You're really going to struggle with that communication. That's really, really critical. I just came from teaching a class to speech pathology students that I teach every year. It's one of my favorite classes to teach. And I taught that from 5:30 to 6:30 tonight, right before you guys. And one of the things we talk about is somebody who's had a stroke or a traumatic brain injury, how difficult it might be for them unless we enhance the situation. And there's lots of ways to enhance the situation. And we'll talk about that a little bit. I know that Christina talked about that a little bit last week. We'll talk about it more functionally if you want to. The other thing that the World Health Organization says to us is that we need to look at the social and emotional impact of hearing on a person's life. Being excluded from communication has significant impacts. It can cause feelings of loneliness, isolation, frustration. It can result in anxiety and depression. And this isn't just the hearing loss on the audiogram at that tip of the herb or iceberg. This is the whole process. The other part of it is we know that you as a communicator are only half of that, what we learned somewhere in school is the communication dyad, that you have a speaker and you have a listener. And if you're the listener on this, it can be really problematic for you because you may want to know what somebody's saying and they're speaking too quickly, or you're in a noisy environment, or you've now all of a sudden the ringing in your ears came on and you are frustrated because you need them to repeat it for you. And what do they often say? They either say it louder or they say, never mind, it wasn't important. Well, maybe it was important. Maybe you don't want to feel left out. I see a hand up. Let me see if I can get you. No, I can't get your name. Go ahead and tell me your name, and I got your hand.
Perry Christensen.
Hi, Perry.
Hi. I had some problems. I had two TBIs and a coma. And right after that happened, I became very jumpy with sounds. That may have been what you were already discussing when I started. I got on late. And before that, I was not jumpy at all with sounds. Like, I don't know, staggering or how to phrase that. But if I hear a sound now, it'll make me jump a lot real bad. Is that what did that, or what is, how can I deal with that?
That's often called hyperacusis. It's a small term for it, but the bigger term is sound tolerance issues. And that's often because of where your traumatic brain injury injured. That jumpiness is called a startle response.
That may be, and my balance is off too.
Yeah.
Right,
have you had treatment for your balance? Has somebody worked with you?
A little bit in the past, but I'm done right now, but I may get back to it. We'll see. I'm going to be working with a program, volunteering for a program, doing some physical therapy type stuff.
Awesome.
Yes, I know it's weird. I did not do it up before at all either, like jumpy type thing. Like if a car backfired, that wouldn't matter to you. I wouldn't even notice it.
Yeah, there are things that can be done for that. The first place to start is with a hearing evaluation that also looks at that sound tolerance aspect of it. So most audiologists don't do that when they're working with somebody. And because if you're working with somebody who's got experience with someone who's had traumatic brain injury, you know that, especially somebody who's been in a coma, you have to approach it a little bit differently. And there's questionnaires that we can use. There are methods for assessing that, but there's also methods for treating it. So, and I know it's
Right.
going to sound,
I'm
Yeah.
familiar with Pressy Hall, and I'm also familiar with people with problems like you're talking about, can't hear in
Mhm.
noisy situations and stuff. I'm familiar with that too. All right, not me, but I know people like
Yeah,
that.
yeah. And ironically, one of the ways that you can treat that the research tells us and that we use, it sounds counterintuitive, but there's ways you can use hearing aids for it, because one of the reasons that they think that the brain is so jumpy to that is because the perception of foreground information and background information, like you said, you didn't have that before your TBIs, now is messed up a little bit. And so
Right.
how do we get that back into alignment is really what we're talking about. So that's a really great question. And it's something, unfortunately, is more common than we know. But there are ways that you can address that.
I didn't, it was like so 100%. That's why I noticed it was like I never did it before, but now
Mhm.
I did that right after that, like right from day one, started doing it.
Mhm. Do you have ringing in your ears also?
No, not really. I like listening to music a lot,
Good,
but
good.
I don't notice the ringing. It's the kind of thing I mean, I might have it more if I pay more attention.
But there are things that you can do. It's just kind of getting a measure of how that loudness affects you. And there's ways we can do that as an audiologist. So I would recommend, a place to go if you haven't had somebody look at that sound tolerance aspect of it is to do audiology.
Pressy Hall, I don't know if you know anything about that, but
I'm the
that's
director of the clinic there. So,
okay.
so yeah, I know a little bit about it.
The
And
clinic
have been for a
too.
really long time. So yes,
But
and
yeah,
we would love to see you if you want to come over and
I
talk about
have
that issue.
hearing problems, so that's obviously why we never looked at it or anything.
Yeah, no, that's something we absolutely could do there. So
Yeah, okay,
I,
yeah.
I appreciate your question. I'm going to move on to the next slide.
Go right ahead. I'll
So,
be quiet.
oh no, you're welcome to chime in whenever. One of the other aspects of this is looking at post-concussive syndrome. We think that people can have lots of issues going on, but we think that they go away pretty quickly. And that's really not the issue. That's really not accurate. They can last for weeks, months, and or years after the head injury. And the kinds of things that happen in a post-concussive syndrome, as many of you are familiar with, is that people will have headaches, dizziness, tinnitus, visual perceptual issues, auditory perceptual issues, anxiety, depression, short-term memory issues, and lots of other symptoms. And the reason I wanted to put anxiety and depression up here, and I've already hinted at this, is one, having hearing issues can result in anxiety and depression. Having balance issues can result in anxiety and depression. And there's often a synergy or kind of a intersection, a negative intersection with all of these things as they come together. And what I always tell audiologists, what I'm going to talk about tomorrow, is that we have to be on the lookout and very careful for what you guys tell us. That if you come in and say to me, Gail Whitelaw, I have problems with my hearing after my TBI, I can't just do that audiogram and say, oh, you look great. I've got to find out what's going on. Karen, I wasn't trying to ignore you. I know you had a question. So if you want to just tell me what you were wanted to ask. You said you couldn't find the hand, and people were very nice about helping you find the hand. But if you want to just go ahead, Karen, go ahead, ask away.
Just a quick question. When you say auditory processing disorder,
Mhm.
is that considered a brain injury itself, or is it, because when you say auditory processing disorder, everybody thinks of the ear.
Right.
But
It
the
is a brain
processing
injury.
is in the brain, right?
It is a brain injury.
Oh.
I always say that audiologists own everything from the part that you can see outside the pinna all the way up to the, the brain. And we've got to look at all of that. So when somebody comes to me, and I've done auditory processing disorders have been part of my practice for 38 years. I love that population. And as a brain disorder, it can either be acquired, like through a traumatic brain injury, or a gunshot wounds, obviously a traumatic brain injury, or through a degenerative disease such as multiple sclerosis, or it can be developmental, and it can be present from childhood, like more of a learning disability. But you're absolutely right. Great question, great comment. It is a brain disorder. Yes.
Okay, thanks.
Yeah, sure. We could talk about auditory processing disorders all night. One of the things that I think is important for us to think about also, and Perry brought this up, that a number of people who have had concussions, traumatic brain injuries also have vestibular issues, and they come from lots of places, but they often come from the ear. And we know that there needs to be an assessment for this and vestibular rehabilitation. One of the frustrations that I have as an audiologist, I don't do balance, but many of my colleagues do, and they do it really well. And people who've had traumatic brain injuries don't seem to get to audiologists. They seem to skip this part where they go right from having a balance issue to getting vestibular rehab. And oftentimes the vestibular rehab isn't effective, and they don't know why. Well, if we didn't look at how the inner ear may have been damaged and some very specifics about that, I'm not sure, it's like jumping to the end. You're reading the last chapter of the book before you know anything in between. So I'm very picky about that. And when patients come to us, I will often send them to see an audiologist with balance disorders. There's a national certification that audiologists can get that qualifies them to evaluate and treat balance disorders. Physical therapists can get it too, but audiologists have really sophisticated equipment to be able to take a look at some of those things. And that's not to criticize at all what physical therapists do. It's just to say, if a PT does treatment and it hasn't gotten the person to where they want to go, there's more that can be done. So hearing and listening are often overlooked. I've said that already. We know that research says that up to 75% of people with TBI have residual hearing issues, many of which are subtle, but subtle does not mean insignificant. That's always something that I want to point out to people. And I'm going to tell you a story about one of my very most interesting and favorite patients here in just a little bit. The frustration I have is that sometimes professionals tell people, just try harder, or the hearing is okay. And maybe that was done by a physician who would do a whisper test in their office, which, by the way, isn't calibrated and isn't a way, or they might use a tuning fork. Maybe you've had a tuning fork test before. Those are not, yes, or yes, Karen's got the, maybe I'll rub my fingers by your ear. Those are not ways to evaluate hearing. They don't tell us anything. They're very inaccurate. And hearing issues can be very, very subtle. And sometimes people don't realize they have one until the auditory system is taxed. And that might be when the person goes back to work after their head injury, or a child goes back to school, a teenager goes back to school, as I mentioned before. And now all of a sudden they thought everything was good with the auditory system, but the wheels fell off and they're really struggling. And this all begins with good testing. So I'm a great believer that investing in a hearing evaluation is the best place to start. Perry brought up where I work. I'm not doing a commercial for where I work at all. I would love for you all to come and see me, but there's lots of great audiologists in Columbus, Ohio. In our clinic, we are underwritten by our college to do the mission that we have. And so there's no charge to come and get an evaluation. And most hearing evaluations are not very expensive to have, and most are covered by insurance. So I think that that's a really, and I know I'm biased by this because I'm an audiologist, but I can tell you that that's a really great place to start. And it has to be a comprehensive audiologic evaluation. Last week, Christina probably talked about the auditory processing scale, the adult auditory processing scale, the APPS that she's created, and it's fantastic. And it really targets in on a lot of the things we're talking about tonight, the auditory processing aspects of this. We also want to use a specialized case history form. I care that you might have had ear infections as a kid. That's kind of interesting. But I really care about what your perception of your abilities are since you had your traumatic brain injury. What happened if you were hospitalized, like Perry's situation? What happened, when you were discharged from the hospital and 3 days later you had this terrible ringing coming on? I want you to tell me your story, because the subtleties of your story often help me help you. And so that's the thing that's really important after a head injury. And I can say that about a lot of things, but maybe because I see so many people with traumatic brain injuries, I hear their stories so often. And there's a lot of similarities in those stories of things that audiologists have overlooked, or they were told, just listen harder. If you could, you would. Nobody wants to be that person who's like, I didn't hear what was going on, or I got left out, or it was so noisy for me, I had to leave the room, or I got tired of people saying, never mind, because I wanted to mind. I wanted to know what was going on. So we want those issues to be addressed. The hearing evaluation is the first part of it, and that's the part that you all know. You hear a beep, you push a button. You hear a beep, you raise your hand. We look at that. The most important thing that I can do after you've had a head injury is something called a speech and noise test. And it's very simple to do. It takes about 2 to 4 minutes for an audiologist to do. And I should say, in somebody with typical hearing, if somebody has a slower rate of processing, if somebody has had a traumatic brain injury and their processing is slowed, or they have a hearing loss, it may take a little bit more time. One of the things I'm pointing out to you is that our research tells us that only 15% of audiologists do this testing. It is part of my standard of care. So anybody who comes to my clinic who says, I can't hear well in noise, should have this test. We do it routinely on almost every patient that we see. 15% of my colleagues do it. So if you went to see an audiologist and you said, well, I have trouble hearing in noise, and they said your audiogram is normal, the tip of that Erber's hierarchy is normal, they didn't get the stuff that you are complaining about that's so difficult for you. And this is related to Karen's question. If I were doing an auditory processing evaluation, I would have to find ways to make the brain work hard. So I would have to add background noise. I would have to try to trick your ears in not working together as a team, because that's what they're supposed to do. But I will tell you that sometimes if somebody's had, say, a left temporal lobe problem, they were hit in the left side of their head, and it's in that area back where your auditory system is, your two ears stop working together well. So patients will come in and say, gosh, my right ear still sounds kind of the same way as it always did, but my left ear is way off. It sounds echoey. It sounds funny. It's different than it used to be. All of those things can be done if we know how to tax the auditory system. Lots of people that have had traumatic brain injuries talk about timing, that they used to be able to follow fast or rapid speech, and now that's destroyed. They can't, if somebody talks quickly, they can't follow them. And going back to my example about working with a physician, for example, you have a doctor who speaks really quickly, and they come in and they rattle through it and they tell you all this, and you're not sure what went on because you can't process the information effectively. And they may say to you, but you have normal hearing. Well, no, there's more to hearing than just this. Last week, Christina talked about HD, or hearing difficulty. We talk about it. I present with somebody else and do some research with somebody else who talks about SAD, which I hate that acronym, but it's called suprathreshold auditory deficits, which means if I only test you at the softest level you can hear at, I don't learn very much about you or your auditory system. If I listen to you and you say, holy smokes, I used to do really well, Gail, when I was in a, in a noisy room. And now I avoid restaurants. I can't work in my work environment. I used to enjoy going to meetings, and I can't go to meetings anymore. I need to listen to that, because we test those tests at a level that's at a comfortable listening level for you. And we try to find a way to tax the auditory system. So it's really important to know about that. that super threshold auditory deficit. If a person has tinnitus or sound tolerance issues, and this was the question that Perry was asking or the comment that he was making before, we need to find out about the parameters of the tinnitus. I mentioned that tinnitus is a symptom and not a disease. There's no cure for it, but we can make it livable. I do this every day with patients. And so I want you to know that if you come in and you say, I have ringing in my ears, we're going to spend a whole lot of time talking about it. When you leave my office, your ringing is going to sound worse for a little time because we put a lot of concentration on it. But in the long term, we get it to be much less of an issue in your life. We want to know, how do you perceive it? How loud is it? What pitch or frequency? And what Perry was saying, when something is loud, how loud is too loud? If it's too loud for you now after you've had a head injury, we want to find out a little bit more about what's going on in your auditory system. And all of these things are testable. So just to let you know that, you know, if somebody hasn't asked you these questions, we can test that stuff. Balance testing, I've already hit on that. And the balance testing that an audiologist can do is different from what a neurologist or a physical therapist can do. It's more specific. It looks specifically at the inner ear. You know, balance can come from your feet or your seat or your heart or your head, your inner ear. And so often if somebody's had a traumatic brain injury, they have issues with mobility, right? They may have a spinal cord injury. They may have a foot injury or leg injury. They may have a cardiac issue. All of those things can contribute to imbalance, but the inner ear is my territory. It's where, you know, where audiologists live. So important to think about that. There's a ton of technology that we can use. I'm over my 20 minutes now. I know that for my little talk here.
Gail, that's okay. I think there's one or two questions if we can get to
Oh, I
those real
see.
quick.
Yeah, Karen, go ahead.
In regards to the auditory processing testing that you do, if someone like me, for example, has hearing loss, tinnitus, and hyperacusis, how do you perform that without causing setback? And how do you differentiate between what's the hearing loss and what's...
It's a great question. And clearly you've thought about, that's an incredible question. I will tell you what the research says and what my own clinical experience says, that we work on the sound tolerance and the tinnitus first and try to get those as much under control as we can. Then we look at hearing and auditory processing as secondary issues. I don't want someone to have a setback. And we work specifically on the tinnitus first because so many people talk about the fact that their tinnitus makes it hard to process information. It takes away attention. It's constantly there. So we often work on that first. And then we look at how the hearing loss and the auditory processing may go together. One of the things we may do is we may look at some mild gain hearing aids on that, which again, I know sounds counterintuitive, but there are ways that we can do that very carefully and easily. And it can work with sound tolerance issues also, because many times the sound tolerance issue is a type of auditory processing deficit. It's an imbalance in what you're hearing, and we need to try to bring that balance back in place. Does that help, Karen? Did you want to?
Yeah, basically, it's complicated.
It is complicated. It is complicated, but not impossible to work with, for sure. For sure. Is there another question? Something in the chat?
No, I think we got everyone.
Okay, fantastic. All right, so how do we manage this stuff? Karen just asked, the use of hearing aids for people with hearing loss works effectively. And one of the things we also have to get people to get past is that these are not your grandparents' hearing aids. Current hearing aid technology is truly amazing. And I can put it on people and do things with this that would shock you, not physically, but in a positive way. It would shock you of how good it is. That Bluetooth connectivity is amazing. Remote microphones are amazing. And there's technology on phones such as a Live Listen that goes right to hearing aids. So if you are that person who can't go into a noisy environment, either because noise is too loud for you or too soft for you, speech is too soft for you, we have lots of things we can do through that. We have hearing aids that we use on people who have normal hearing also. They don't have normal hearing, they have normal audiograms. I have fit many people with traumatic brain injuries with hearing aids over the years. So, you know, we don't make any money on hearing aids in our clinic. We do a lot of research on hearing aids. And so we are able to do things that other places can't do. And if somebody ever wants to come over and do a trial, happy to do a trial with you. I have lots of hearing aids I can put on people and try stuff out. And we have a whole lot of fun, I think, patients think too, doing this. But there's also another component of teaching future audiologists what to do when they encounter somebody who has had a traumatic brain injury, and also letting the brain injury world know that this technology exists and it's quite amazing and does some really amazing things. It can help to support areas of timing that are deficit now, directionality, which many people after they've had a traumatic brain injury aren't good at finding direction anymore. Excuse me, speech and noise does great on those. So these are things that we want to make sure that you're aware of and might try with hearing aids. My cursor is sleeping. The hearing aids must be well fit. And if you were to get a hearing aid, either for normal hearing and some of the issues, the auditory processing or tinnitus issues that we're talking about, or you did have a hearing loss and you wanted to try to boost that, only 30% of audiologists do this thing called real ear measures. And so I hope tonight will empower you for yourselves or for other people to tell audiologists how we should do our jobs better, because we need to do that. The other part of it is there's now something called over-the-counter hearing aids. You see them advertised all the time on TV. You might get Facebook ads for them, or you might get emails for them. For people with traumatic brain injuries, it's not the product, it's the process. You need to see an audiologist who's experienced with this population, because you can't just slap a product on and be happy with it. If Perry slaps a product on, he might find that it's way too loud for him and there's no controls for that. If Karen slaps a product on, it may not address her tinnitus effectively. And the other part of that is they can't give you an effective trial period or an appropriate trial period. Hearing aids need to be tweaked and adjusted when you first fit them. And for that, we really want to make sure that we're doing that it's being adjusted for you. There's a remote microphone system, which is a device that's worn in the ear, almost like a cell phone receiver, and it has a wireless microphone with it. And you can only hear what's coming through the microphone. So let's say you go out to dinner with your friends and you use this little remote microphone. Some of them sit on a desk, some of them are clipped onto a shirt. You can hear that person like they're 6 inches away from your ear. So you're not struggling with all the overwhelming cacophony of sound. You're hearing the speech and only the speech. This can also be coupled to a hearing aid. So there's a couple of different ways this can be done. And it's really, really effective for listening. And then we know that technology results in reducing auditory fatigue, reducing the cognitive load, helping retrain the brain, and helping to address issues with tinnitus. And surprisingly, as I said, sound tolerance issues. So hearing aids can help with all those, not for every patient, but it can help with each and every one of those issues. There's also programs that are out there that you can use for retraining the brain that are a lot of fun to use. They can be used with or without hearing aids. One is called LACE. It's an adaptive program that teaches you to listen in noise better. It has to be done over about a 45-day period. And so for many people that I work with traumatic brain injury, it's intensive, and they may do it once, do it for 45 days, quit for a little bit and come back and do another 45 days. But it teaches how to listen in background noise. There's also another really fun one that we've been using. It's evidence-based. I don't like the name of it. Its name's kind of stupid. It's called Amplify, but it's a fantastic app. And it allows you to look at a number of different listening skills that we've been talking about. Listening in noise, timing, how do your two ears work together, and does really specific evidence-based approaches for building those skills And they made it like a little contest. So you can go in and play a game with somebody else or whatever you want to do. But it's really a fantastic program. It is, they let you try it for 2 weeks for $1. And then I think the cost of the program through Amplify is $120 for like 10 or 12 weeks. So it's very reasonably priced and intense. And my patients that have tried it have thought it was really fun. I've used it with a number of people that have had traumatic brain injuries. So we want to work with the team with the speech pathologist. You're going to hear Katie next week. I look at the bottom up process, and this was related to the question that Karen asked before. How does the information get from the ear to the brain? That's my purview. Once it gets there, how is it organized, categorized, available for quick recall? And that's what the speech pathologist addresses. So presumably we work together on a team, and we're both doing, different things, but with the same sensory systems, and trying to build it from 2 different approaches. And that's really effective. And many times people don't have speech therapy services once they either leave the hospital or it was deemed that they weren't important. And I find it very frustrating, because I will tell you that I think that those services are critically important to the patient population that I work with. Many times the decisions are made based on what your insurance will pay. And there's other options that are out there that are low cost or no cost if you ask around a little bit. And I'd be happy to share those if anybody sends me an email and wants to think about how you do speech pathology services that don't cost an arm and a leg at a medical center. There are other ways to do it, and I will help you with that. So I already mentioned that there's lots that can be done about tinnitus. We want to try to help people who have tinnitus to improve the quality of their life through what we call habituation. So it's not masking or covering it. It's having your brain interact with it. And it works really, really effectively. And cognitive behavioral therapy in conjunction with audiology treatment is the best way to approach this, the absolute best. Vestibular rehab, I've already hit on that a bunch of times. So there is a vestibular rehabilitation support group at Ohio State, and I see patients from there, and I refer patients to there, and people really like what they have to offer. And I want to just tell you about a patient of mine that I think is really interesting, and hopefully you'll think is interesting too. And there's so much more to talk about, but I want to give you a little bit more time for some questions. I saw a patient a number of years ago who was a survivor of the Boston Marathon bombing. She is a remarkable woman in every way. She's one of my favorite patients of all times. She was an avid runner, a physical therapist, and left her practice of physical therapy to become an angel investor. And what angel investors do is they find people who want to invest in businesses, kind of like Shark Tank, if you've ever seen that TV show. People who want to invest in businesses with people who have great ideas, except oftentimes they're healthcare related or philanthropic. And she was an angel investor at this point in time, very motivated by her work, loved her job. On the day of the Boston Marathon bombing, she was crossing the finish line when the first bomb went off and was knocked to the ground, and went to get up and looked up, and all of her friends who had beat her in the race, which made her really angry, ended up sitting on the knoll and had arms and legs that were blown up, and they were in the aftermath of the bombing. And as she was trying to head over that direction, the second bomb went off and a police officer jumped on her. So we don't know what of her traumatic brain injury was hitting the ground and what was somebody trying to protect her, but she ended up having a traumatic brain injury, the extent of which wasn't fully known at the time. That was in April. And in July, she went back to work, and she thought she was just fine. And one day her business partner pulled her aside and said, you don't hear like you used to. You're not good at this hearing stuff. You're not good at listening anymore. And she went home and she said to her husband, is that true? And her husband said, yeah, you're kind of not good at listening anymore. Like when we go out to a restaurant, you're lost. And she started thinking about things, thought she had auditory fatigue. And she went to see an audiologist. And she said, I can't hear a noise is what my problem is. And they tested her hearing, and she had normal hearing. They told her she was fine. She went to 6 more audiologists who all told her that she had a problem in her head, and it was her emotions. that she had post-traumatic stress disorder, which she indeed did have, but it wasn't related to her hearing. And they found that her hearing was normal. So one night she went to this support group for people with hearing loss. It's called HLAA, Hearing Loss Association of America in Boston. And one of my very dear friends was presenting there. And he left the meeting, and at about 1:45, I got a text from my friend Brian, and he said, there's this woman I met tonight. She's coming to Columbus to see you. Find a time for her and, put her in your schedule. And I was like, this is strange. Pray tell, what does she need? And she and I talked on the phone. She came around the holidays in December, and she told me she was going to be really, really mad at me if she came and I didn't do anything to help her, because she already knew her hearing was normal, but her hearing wasn't normal because she couldn't hear. So she gets to Columbus, she flies in, she gets to Columbus. We put her in the booth and we do that dumb hearing test one more time because that's where I start. And she said, I've had this. I told you I was going to be mad at you. And I said, I know, we're getting there. And we did the first speech and noise test. And she started to sob. And she said, this is what's wrong with me. This is the part I can't do. And her speech and noise results were horrible, horrendous. And we did the auditory processing testing. And she couldn't do that either. She was terrible at everything. And she said, why didn't anybody else do this? And I said, I don't know why anybody else didn't do this, but let's talk about how we move ahead. So we fit her with mild gain hearing aids. And it was really hard for me to convince somebody to do this because in our community, people do this. And in Boston, they didn't. So I was lucky. I had an alum of our program who worked there who fit her with hearing aids. And I wanted her to have medical clearance from an ENT, from just an otologist. They only do ears, a specialized kind of ENT. And I had worked with somebody through the Cleveland Clinic, and he saw her, and we got her going on these hearing aids. And we also got her to see this fantastic speech pathologist who worked at Boston University, who's since retired. And the quality of this woman's life changed so dramatically. In 3 months, we did a conference call, because in those days we didn't have a nice Zoom like this. We did a conference call, and she sat and sobbed and said what a difference it had made. And she was able to go back to her job. She was able to go back to socializing. We did auditory training with her. And I guess I tell you this story to say, I'm embarrassed that my profession didn't do a better job with her. And I'm heartened. And I don't feel like I want to be the hero of the story. She's the hero of the story. But there were people who could get together and work as a team and address her auditory concerns and make things better for her. And so there are those possibilities once someone has had a traumatic brain injury for somebody who's willing to look at it as an audiologist. My heart breaks for somebody who's been to 7. I mean, she was persistent. She saw 7 different people in a city where healthcare is, preeminent. And it made me laugh because she said that one of the ENTs said to her, it was all in her head. And she said, I'm trying to tell you, yes, it's all in my head. I've had a traumatic brain injury. I get that it's all in my head, but they weren't willing to entertain that. So she will always be one of my most compelling patients to do a good job at what we do. All right, I'm shutting up, and I have like another 6 minutes, and then I have to go do this thing at this meeting here. So questions you have, something I didn't cover, something that Tina didn't cover last week that you'd like me to talk about?
All right, Michelle's got a question. Go ahead, Michelle.
Hi, thanks for your presentation. And I just have a thought. I never really thought of myself as having the tinnitus or tinnitus, but for a long period of time, I could hear my heart beating in my ear, and it was the more damaged ear, the left ear mainly, but I could hear it in both. And it used to drive me crazy. And what I did, I didn't know what to do, but what I did, I just turned on the TV, or I turn on music.
Yeah. And
then what I do, I try to change my thinking. So is that actually tinnitus?
it can be tinnitus or tinnitus. That's often called pulsatile tinnitus. And if you haven't had that checked out, Michelle, that's one of the ones that they can often find a reason for, something like an open eustachian tube or whatever. So that one's worth seeing an ENT for. Most of them they never find an answer for it. But what you're doing, I would encourage you to do.
Yeah, but it stopped.
Yeah, there's
I finally.
yeah.
Yeah, finally
That's
stopped.
fantastic. That's
I know.
fantastic. Hey,
So,
you know what? If you can figure out why they can bottle that, you'll be a millionaire.
Oh,
That's
yeah.
fantastic. I'm so glad to hear that.
oh, that's great. Well, I never knew it was that like ringing in the ears. I thought it was something completely different. Okay, well, thank you.
Sure.
I might want to come to your clinic. I have a hearing aid, but I hate using it.
Oh, I don't like to hear
Well,
that. If there's something we can do to make it better for you, we would be happy to
maybe.
do that. And
Oh, thanks.
you just have to make an appointment, come in, and we can work with you with that. No problem.
Oh, that's great. Thank you.
You're welcome.
Any other questions out there? Everybody's used to me asking like a million questions at this point. So, but I'm not going to. We only have 4 minutes.
Karen, did you have another question?
Yeah, I know you said before that you work on the tinnitus before you work on the hyperacusis. I went to the tinnitus management clinic at the Cleveland Clinic and found that it basically put me over the edge with the hyperacusis. I had a setback from it. And I need to work on the hyperacusis before I work on the tinnitus. But I have hearing aids that were adjusted, but even just wearing them, I mean, I have this constant burning and sounds hurt. I have pain hyperacusis.
Yep.
And I don't know if you've had patients in the past that have had pain hyperacusis and how you dealt with them, and were they responsive to treatments, or did you have to like think out of the box, or?
Had to think out of the box. You know, when I first started working with people with hyperacusis, they would report ear pain and I would say, oh, that's impossible. And then I was like, what an idiot. I was stupid. I didn't listen. And I always learned the lesson that if I don't listen to patients, I always get burned. And the current research talks about the 4 types of hyperacusis, and that's certainly a type. Less people have that, but it's certainly a type of hyperacusis. And we've worked with like pain management folks to address that. I've worked with some OTs to do some sensory integration kinds of issues that have helped with some folks. There's some thought that, you know, some anti-anxieties help with that. Some medications help with that. And it's kind of funny because you brought up the Cleveland Clinic. They're usually my place where if I've got somebody who's got both hyperacusis and tinnitus, I send them there. We work really closely with Dr. Cherian and his team, but you know, there's
I know Dr. Cherian, yeah.
There's certainly things that can be done that we've had some success with. And I hate to say I never treat anybody as a guinea pig, but sometimes it's just a trial and error of we tried that and it didn't work. So how about going back to this or thinking about this? And even for some, there are times, and I'll tell you honestly, that we're not supposed to use like hearing protection, but I will tell you that getting somebody through a short-term period, I have created custom hearing protection for them from time to time, even though philosophically I don't believe in that. For some of my patients, they're in this pain thing all the time. So sorry, that they really struggle with that. So I think that there's more trial and error when you're looking at 4 different areas than when you're just looking at not just, but at hyperacusis alone or at tinnitus alone. You know, tinnitus to me is so much easier than hyperacusis as a solution. So if I were looking at you, I'd say I have the advantage of being an armchair quarterback. I'd say, what are we going to do about the hyperacusis and how do we focus on that?
Okay, thank you.
You're welcome.
Gail, one last question, and then we'll let you go.
Yeah.
Who do we email or how do we get in contact to get an appointment with your clinic?
If someone emails me at whitelaw.1@osu.edu on the first slide, I am happy to facilitate that. People can call our clinic. The number is 614-292-6251. However, it may just be easier to email me and I'm happy to try to facilitate it.
All right, I threw those in the chat. Thank you so much for your time. I know that you've done presentation after presentation after presentation with this, and it's great to see the evangelism and the empowerment that you're putting into these talks.
Thank
It's
you.
really, really
And
cool. So,
I'm always happy to talk to anybody about this topic at any time. So,
well, we'll take you up on that for sure.
all right, sounds good. Everybody have a
good.
great night.
Okay, take care. Thanks, everybody.
Bye-bye. Thank you.